Eva is an adult endocrinologist and assistant professor of medicine in the Division of Endocrinology at Brigham and Women's and Harvard Medical School in Boston. She completed her internal medicine residency at Yale New Haven Hospital and her endocrine fellowship at the Brigham and Women's Hospital, and postdoctoral training in the endocrine unit at Mass General. Her clinic is focused on treating adults with skeletal disorders. She leads a translational research laboratory aimed at investigating the molecular mechanisms underlying the pathophysiology of complications of skeletal disorders like XLH. Currently, her lab is interested in determining how vitamin D and phosphate regulate skeletal processes. So something that is dear to many of our hearts. So Eva, we're just so pleased to have you with us today, and we thank you, and we turn it over to you.
Oh, thank you so much for that introduction. I'm just going to share my slides here. You can see it okay?
Oh, looks great.
Yep.
Thank you.
Great, thank you so much. So first, I just want to start with the review and overview of vitamin D, the enzymes that regulate the metabolites, and a little bit of physiology behind what causes rickets and osteomalacia with these enzyme deficiencies. So we know that the skin produces 7-dehydrocholesterol, which again gets produced to vitamin D3. And then in the liver generates 25-hydroxyvitamin D3, which is what we check in circulation and what we see in laboratories and clinic. And the 25-OHD then gets converted to 1,25-dihydroxyvitamin D3 in the kidney by the enzyme 1-alpha hydroxylase. So 125D is generally regarded as the active form of vitamin D. The metabolites are considered more inactive, though there is actual evidence that they perhaps have some activity at the VDR, but much less so. So 125D acts in 3 different arenas. It acts on bone to increase bone resorption and increase calcium phosphate release. It increases intestinal absorption of calcium phosphate and also acts to suppress PTH secretion. And so the vitamin D receptor itself is a nuclear transcription factor. There is a DNA binding domain where there's 2 zinc fingers that bind to the DNA, and there's a hormone binding domain that binds 125D. There's also a cofactor RXR that the VDR has to bind to in order to function properly. And so this binding of the VDR to the DNA then regulates transcription of a variety of different genes that then regulate skeletal processes and other things that vitamin D is responsible for. There's a variety of different enzymes that regulate the vitamin D metabolites. And so the conversion of vitamin D3 to 25-OHD3 in the liver is regulated by CYP27A1 and CYP2R1. And then 25-OHD3 is converted to 125D, and with CYP27B1 in the kidney. And then there are a few enzymes that are responsible for the catabolism of vitamin D, so the breakdown of 125D, including CYP24A1 and also CYP3A4. CYP3A4 being located in the liver. So multiple of these enzymes are actually mutated and therefore cause these rare disorders of vitamin D metabolism. And first, I want to review the action of 125D to just better understand the physiology behind these disorders. And so 125D promotes intestinal calcium absorption. It does so by regulating it regulates osteoclast bone resorption, and also decreases PTH gene transcription and cell proliferation in the parathyroid glands. And so vitamin D promotes intestinal calcium absorption in the duodenum by increasing or regulating the transcription of a variety of genes that then get translated to proteins, which are responsible for calcium uptake in the duodenum. And it also helps regulate, we think, passive transport of calcium from the intestine into the blood. So the absence of the VDR dramatically impairs intestinal calcium absorption in both mice and humans. So it's a key function of 125D mediated VDR action. And so 125D binds to VDR and then also stimulates the production of rank ligand in osteoblasts so that it can indirectly activate osteoclasts, where this rank ligand binds to rank and then activates osteoclasts, and that leads to bone resorption and calcium phosphate release. It also promotes distal kidney calcium absorption by also regulating genes in the distal renal tubules that help regulate calcium uptake in the kidney. And so although 125D and the VDR regulate calcium, it also regulates phosphate homeostasis by inducing bone resorption and also increasing renal reabsorption of phosphate and suppressing PTH, which usually increases urinary phosphate wasting. And so in the combination of these functions, increases serum phosphate levels. And so we know that vitamin D deficiency leads to a decrease in intestinal calcium absorption, which can lead to hypocalcemia. This increases PTH levels in compensation, and then this increases hypophosphatemia or phosphate wasting. So this hypophosphatemia can lead to rickets and also osteomalacia, which is the impaired mineralization of the skeleton. And so there's been mouse studies have shown the critical role of phosphate for normal growth plate maturation. So we know that in mice that lack the vitamin D receptor, there's expansion of the growth plate where you see these increased thickness of the hypertrophic chondrocytes at the mirroring growth plate. When then given a high calcium, high phosphate diet, you can see that the growth plate normalizes in the same as wild type. Hip mice is a mouse model of X-linked hypophosphatemia. And when these mice are fed low phosphate diet, they both have growth plate expansion, suggesting that it's really downstream actions of the VDR, and namely serum phosphate levels, which is really regulating growth plate maturation and therefore really underlies the physiology behind rickets. And so when we look at the VDR knockout mice, when they are just on regular diet, you can see that they have this black space in the growth plate. This is the growth plate expansion, widening of the metabolism. So this is evidence of rickets and poor mineralization. But that when they are on the high calcium, high phosphate rescue diet, that the bones appear very similar to wild type, where the growth plate closes and the mineralization improves, suggesting that it's downstream actions of the VDR, including its ability to regulate calcium and phosphate, which is really critical for growth plate maturation, is very important for skeletal mineralization. And so when the VDR knockout mice are fed normal diet, there really isn't much mineral being deposited, so you can't see the double labels. But when they are on the rescue diet, high phosphate, high calcium diet, you can see that there's restoration of the mineral apposition rate, where you can actually see two labels again when calcium was injected at two different times. So there's restoration of mineralization. And so these are some 3D renderings, histology pictures of the effect of osteomalacia due to vitamin D deficiency. So you can see in normal bone, there's thick cortices and a very intricate form of trabeculi. And that during osteomalacia, the cortices are thin. There's a lot of this red color, which is osteoid or poorly mineralized bone. And then the trabeculi are much thinner. And so 125D is also important for parathyroid function and parathyroid hormone levels. It decreases parathyroid cell proliferation. It decreases PTH gene transcription and decreases PTH levels independent of calcium. But humans with VDR mutations have normal PTH levels if infused with calcium, and the VDR knockout mice do not develop hyperparathyroidism if kept normal calcemic, showing that in vivo effects of the VDR and the parathyroid are actually compensatory. And so really it shows the importance of the downstream effects of the VDR when it's an ability to regulate calcium. And so the VDR is not essential for prevention of hyperparathyroidism, prevention of rickets, or bone mineralization or normal bone strength. And so in the clinic, when patients are vitamin D deficient or lack 125D, children can develop rickets and can manifest a variety of different clinical findings, including wide sutures, rachitic rosaries, Harrison sulcus, bowing of the legs, swelling in the wrist and ankle joints, the pigeon breast deformity, dental hypoplasia, fontanelle bossing, delayed closure of the fontanelles, all really pointing towards poor mineralization of the skeleton. And so there's certain findings we see in rickets. I think everyone is aware of it. Aside from bowing of the legs, you can have knock knees or genu valgum. There's the windswept deformities where they sweep to one side. There's anterior bowing, and also can be affected on one leg. So this really shows the impact of the weight of the torso on top of the lower legs. Because of the poor mineralization of the bones, they become deformed. And so pathognomonic for osteomalacia or pseudofractures, or at least microcracks in the cortex, they are located in the medial side of the skeleton. And so complications can vary. Some patients can manifest bone pain or muscle weakness. There can be secondary hyperparathyroidism in the setting of vitamin D deficiency and low calcium. We see rickets in children, hypocalcemic seizures, if it's very severe. The bone osteomalacia can lead to fractures. There's an increase in falls and low bone density, especially in the older population. Vitamin D is also important for dental alveolar tissue mineralization. And so there can be impaired mineralization of the mandible and maxilla. There's an increased risk of periodontal disease, delayed tooth eruption, and increased incidence of dental caries. And so in terms of food, there's foods that are rich in vitamin D and also foods that are rich in calcium. And so cod liver oil is the traditional food supplement that we know is very rich in vitamin D, and so are certain fishes. More commonly, we promote calcium-rich foods to patients with skeletal disorders, especially if they're vitamin D deficient, especially since we know that the downstream effects of the VDR include intestinal uptake of calcium. And so you really get the most amount of calcium with dairy, such as milk, cheddar cheese, or cottage cheese, but canned salmon with bones, various foods like tofu, and almonds are also rich in calcium. So I want to move on to the genetic disorders of the vitamin D metabolism. And so there's a couple of different enzymes, starting with CYP27B1, which are mutated and cause these disorders. So there's CYP27B1, which generates 125D. There's the CYP2R1 enzyme that generates 25-OHD, and so therefore that leads to low 125D levels. There's mutations in CYP3A4, so therefore there's increased catabolism of 125D, and mutations in CYP24A1 that leads to hypercalcemia. So first we'll talk about vitamin D dependent rickets, 1A, which is 1-alpha hydroxylase deficiency. It is autosomal recessive, it's heterozygous, a version is unaffected, and it's about 50 cases that have been reported. And so there's inactivating mutations in CYP27B1 that eliminates or reduces enzymatic activity. It's CYP27B1 is expressed in the proximal renal tubules, but there are also local expression in tissues like breast, colon, placenta, and macrophages. And so we know that mice which lack CYP27B1 mimic the human phenotype. So they have low calcium, low phosphate levels, and develop rickets. When they treated with 125D, it really normalizes their phenotype, where serum parameters are normalized, body weight and growth are normalized, mineralization and growth plate maturation are all become similar to wild type. If they are treated with a high calcium diet alone, you can correct the hypocalcemia and high PTH. The rickets and osteomalacia are cured and growth is improved, but not every measure is normalized. I think showing that 125D has some independent effect of calcium. So this is just a table of a listing of a variety of the different mutations that have been found. There have been deletions, premature termination, translation, insertion, so a variety of different mutations found on these different kindreds. And so in presentation in utero, there's really no known pathology because the mom usually has an increase in 1-alpha hydroxylase, and there's increased 125D levels, and she typically has normal calcium levels. But then after birth in children, they usually present prior to 1 year of age. They can have neurological signs like hypotonia and gross motor developmental delay. There's growth retardation because of the hypophosphatemia. There's bone pain, the bone and joint deformities that I had shown, hypoplasia of the tooth enamel, and a hallmark is hypocalcemia, or profound hypocalcemia. On labs, the serum calcium can be very low, so less than 8 milligrams per deciliter. Serum phosphate is low, but a little bit more moderate than what we'd see in hypophosphatemic rickets. Alk phos levels are elevated because of rickets. 125D levels are low or undetectable because of the lack of CYP27B1. 25 hydroxyvitamin D is normal, and PTH levels in compensation are high. So the treatment for type 1A would be supplementation with calcitriol. It's reported that you can require up to 1 to 3 micrograms per day. Usually at age 4 to 9, the average dose is around 0.25 to 5 micrograms a day, which increase a little bit as the child aged to age 11 to 15. And so the outcome of the rickets improves by 2 to 3 months of treatment, and rickets was healed by closer to 1 year after treatment was initiated. And in adults, one has to be careful for hypercalciuria and screening for cornea deposits and nephrocalcinosis. And then to watch out for women who are pregnant, who then require higher doses of 125D to mimic normal pregnancy changes, but to be careful for hypercalcemia. And so in this study, they grouped different patients with BDDR1A and showed that, and the 3 groups are that one group had calcitriol only that was started at an early age, another group that started calcitriol and vitamin D3 before the growth spurt, and another where they started after the growth spurt, so a little bit older. And you can see that the final height z-scores were really the best in patients who started calcitriol very early in age and calcitriol alone at optimized doses versus starting vitamin D3 in combination with calcitriol or starting it later. So this is just an example of the hypoplastic enamel seen in a child with this disorder. And after calcitriol was started, the enamel improved but didn't quite normalize. This is an example of the rachitic growth plate. So you can see that this large kind of black space here and the fraying at the edges of the metaphysis and the widening of the metaphysis and the poor mineralization of the bones, which then improves on calcitriol therapy. The bones appear denser, the growth plates more narrow. This is an example of a patient who had a rachitic rosary. You can see that on an x-ray that there are these kind of large nodules on the ribs, and you can see it overtly on the child here, these nodules on the side. This is an example of pigeon chest deformity, as well as Harrison sulcus on the side here, where there's sort of a retraction of the tissue right underneath the rib cage. And so VDR1B, so vitamin D dependent rickets B, is a deficiency in 25 hydroxylase. So this is a mutation that's autosomal recessive and inactivating in CYP2R1. So then this prevents the conversion of vitamin D3 to 25 hydroxy vitamin D3. And so therefore there's low levels of 25-OHD and 125D. So these are examples of children from Nigeria who had this disorder. You can see that they have, some members of the family had bowing of the legs, some had anterior bowing, and some had knock knees here. And so children typically present with leg pain, skeletal deformities. They may have issues walking by toddler age, and they require very large doses of vitamin D3 to improve rickets. Adults can manifest compression fractures, pseudofractures, and osteomalacia. So in terms of mutations, there have been 5 mutations that have been identified. One that interferes with the CYP2R1 ability to interact with the ligand or interferes with CYP2R1 folding. The heterozygous does have some phenotype, but is less affected compared to homozygous. And there are increases in serum 25-OHD levels after administering vitamin D3, just need very large doses. And so here's comparison of vitamin D levels after administration of a large dose of vitamin D3 in healthy controls compared to those who are heterozygous and those who are homozygous for mutations in this enzyme. And you can see that after administration, that the affected homozygous patients had a very slight increase in 25-OHD levels, but the heterozygous patients had a more significant rise in comparison. And so in comparing family kindreds who have homozygous and heterozygous members. You can see that taking a look at their labs, the ones who are homozygous are profoundly hypocalcemic compared to those who are heterozygous, have normal calcium. Phosphorus levels are relatively lower compared to those who are heterozygous. Alkaline phosphatase levels are much more increased. 25-OHD levels are very low. 125-D levels are low relative to the calcium and phosphate levels. And the radiographic rickets scores are elevated, which then improves after vitamin D3 administration. And so treatment like the 1A is also supplementation with calcitriol. You can use very high doses of vitamin D3 that have been reported from 5,000 to 50,000 units per day. And as the child gets older or into adulthood, the doses seem to decrease, along with supplementation of elemental calcium. And so vitamin D dependent vitamin D dependent rickets 2A are inactivating mutations in the vitamin D receptor, the VDR. This is autosomal recessive, and so this blocks the ability at once 125D either doesn't bind to the VDR, or once it binds to the VDR, it cannot bind to the DNA to regulate gene transcription. And so the mutations can exist in any of the domains of the VDR, including the zinc finger binding, DNA binding domain, the ligand binding domain, the ability to dimerize with RXR, and it can include a variety of different types of mutations. And so this shows the location where these mutations are throughout the VDR, can be really anywhere along the protein. And so children usually present within months of birth with hypocalcemia, with severe rickets and growth retardation. Like the other disorders, they can present with bone pain, muscle weakness, hypotonia, seizures from hypocalcemia, bone deformities, tooth enamel issues, and dental caries. The labs include hypocalcemia, low phosphate levels, high alkaline phosphatase, but unlike the CYP27B1 mutations, they have very high levels of 125D because of the resistance at the level of the vitamin D receptor. And there's also a compensatory rise in PTH. And so these patients are treated with a combination of vitamin D supplementation and usually very high doses of calcitriol to overcome the resistance at the level of the receptor. It's been reported up to 17 to 20 micrograms a day, but this level of resistance can really vary. So the doses can vary depending on how severe this mutation actually is. And also to optimize calcium intake. And so if under some children or patients who have very severe mutations, who are very unresponsive to calcitriol and have very severe resistance at the level of the receptor, they can actually respond to intensive therapy with oral calcium or IV infusions of calcium. So we've shown before, if you treat the VDR knockout mice with the calcium, that the rickets and the mineralization can actually dramatically improve. And these patients' calcium, phosphate, and PTH all normalize. And so this is an example of a patient who had 2A rickets, and you can see that prior to treatment that they had fraying at the metaphysis, and there's also growth plate expansion, poor mineralization, and post-treatment that these bones are much smoother, the growth plate is more narrow, and the mineralization has improved. And this patient was treated with calcium supplementation. And so this is a child, an 8-year-old child who was affected with the VDR2A and infused with calcium. And so these are not pictures from this patient, but it was more representatives. And so pre-infusion, they had very wide osteoid seams. And so then post-infusion, they had normalization that was comparable to control in terms of the amount of osteoid. And so this is just an example of what it would have potential looked like before, with very thick red osteoid things that then normalizes afterwards. And so the VDR, even though we think about 125D in terms of its ability to regulate phosphate calcium homeostasis and skeletal complications, it in fact has a lot of non-skeletal effects, including its ability to modulate, we think, cancers or skin wound healing, inflammatory disorders, and placental health. And so these aren't as well characterized in these disorders as they are sometimes in probably the basic science universe. But one important thing is that vitamin D does, in fact, regulate hair and alopecia, and really comes at the level of the VDR and not so much the 125D. And so when we look at the VDR knockout mice, this is a wild type mouse, the middle is a heterozygous, and the one on the right is a homozygous knockout. And so this mouse it lacks hair and therefore has complete alopecia. And so there's been a lot of research behind how vitamin D or the VDR regulates the hair cycle and alopecia. And we think that the VDR is necessary for keratinocyte stem cell renewal and lineage progression, but that this effect is actually perhaps specific to the VDR and not really 125D dependent. So it's ligand independent actions really regulate alopecia, which is why you see this complication really in patients who have mutations in the VDR, but not the previous forms of vitamin D dependent rickets. And so these are some examples of the alopecia that can be seen in children who are affected with this disorder. There can be patches of alopecia or complete alopecia that is not always responsive to therapy because it is a ligand-independent issue. And so there's also the vitamin-dependent rickets type 3, which are gain-of-function mutations in the CYP3A4 gene. And so CYP3A4 is responsible for the breakdown of 125D to inactive metabolites. So this is an activating mutation. This is shown to be autosomal dominant and heterozygous mutation in, I believe, only one kindred. And so this phenotype can present as early as age 2. These patients have rickets, growth impairment, and is resistance to lower doses of cholecalciferol and calcitriol for treatment. It requires really larger doses since the 125Ds being broken down. And I think the way they found this mutation was that the mutational analysis didn't show gene mutations in the other typical genes that you would find. And so in this child who's only 2.5 years old with rickets, you can see that they have the widening of the metaphysis, this fraying and this cupping here. They have a bowing of the long arm and a subpore mineralization. And then by age 16, a different family member had this metaphyseal lucency and also osteopenia in its bones. And so the labs are very similar to 1B. So they have hypocalcemia, hypophosphatemia, high alk phos levels, high PTH, a decrease in vitamin D, and also a decrease in 125D. And so the treatment is either high doses or a combination of high doses of calcitriol and vitamin D3 to overcome this increased catabolism of 125D that can then normalize labs and improve skeletal outcomes. And so in summary, we've looked at 4 different enzyme mutations that cause vitamin-dependent rickets, including CYP27B1, CYP2R1, the VDR, and CYP3A4. And so they largely are very similar to each other in the sense that they present with rickets, appear very early in age. Their lab profiles are generally similar. I think they're really differentiated based on the 25 OHD and 125D levels, where the 1A has very low 125D. The 25-hydroxylase deficiency has low 25D and also 125D, whereas the VDR has very high 125D levels. And then the VDR3 and 1B are distinguished by the fact that the type 3 requires very high doses of cholecalciferol 125D for treatment. And so finally, I just want to go over CYP24A1 mutations. Mutations in this confers an inability to catabolize 125D. It's autosomal recessive, and so therefore 125D cannot be metabolized to 2425D or 12425D3. So there's also a variety of mutations which can cause this disorder throughout the gene. It usually presents with symptoms less than 5 years of age, and then but can in fact be a little bit milder and range up to adulthood in the 20s to 30s. They have, so unlike all our previous disorders, they actually have hypercalcemia and is symptomatic. And so the symptoms really relate to the hypercalcemia with vomiting, polyuria, polydipsia, weight loss, worsening renal function, failure to thrive, nephrocalcinosis. And so in labs, they have increased serum calcium, high or normal phosphate levels, normal 25D levels, an increase in 125D or inappropriate normal, and suppression of PTH. And so in this particular study, they grouped the presentation of these patients by age. And so you can see that if they present less than 1 year of age, their phenotype, not surprisingly, is much more severe. The calcium levels are much higher than if they presented as an adult. And there's also an increase in percent of patients with nephrocalcinosis and symptomatic hypercalcemia. And then during pregnancy, if you look at the patients during pregnancy, they have much higher calcium levels because of the increase in 125D production. So their 125D levels are also increased, and there's also an increase in percent of patients with symptomatic hypercalcemia. And so treatment really has to do with trying to control the hypercalcemia and symptoms related to it. You have to increase hydration, just continue to have a very low vitamin D and calcium diet. Some patients require fluconazole or the azoles, which blocks the CYP27A1 enzyme. And also, some patients can take rifampin, although I think this is much less common to induce CYP3A4. And there's been some reports of using bisphosphonate denosumab to decrease the calcium levels.